Stream Team, welcome to another episode of Balls Deep. Today I have a very special guest, Dr. Dent Williams. Dr. Dent has spent 40 years behind closed doors with thousands of women, only professionally, I swear. He is an esteemed physician from Montgomery, Alabama. And more importantly, he's my father-in-law. And so I bribed him into coming today as long as we can get him in home for the Auburn game. So with that, Dr. Dent, welcome.
Thank you. Thank you for having me. Absolutely.
Well, I thought it was a great opportunity. You know, you and I talk shop quite a bit back home. And I always value the perspective you have because you've seen a lot in your career.
Well, it's been a long career.
Yeah.
A long time.
Absolutely. And so obviously things have changed, but, you know, I thought we'd just jump right in. Balls Deep. Welcome to Balls Deep, a humorous yet informative medical show with a mission of optimizing your performance in the bedroom, the bathroom, and the boardroom. I'm your host, Dr. Joe Pazona, a board-certified urologist and CEO of Pazona MD. We hope you enjoy. Now, let's jump right in. 4 decades of seeing women in very intimate settings. As a gynecologist, you obviously are there with women, sometimes in their most vulnerable moments. Share with us either one thing or a couple themes that women would talk to you about, but you almost wish that they had spoken with their partners, their husbands. What were things that, you know, you were dealing with women behind the closed doors and really wish they had shared with their loved ones?
Well, sometimes I used to say I did part-time gynecology. They need someone to talk to that will really listen to them. Mm-hmm. Very, very important. And so many times husbands aren't very good listeners.
Careful, my wife, your daughter, is sitting in the room here. I don't know what you're talking about. Yeah, I mean, you were almost part counselor to a degree.
Indeed,
you know?
Yeah.
I mean, what % of your practice was really helping women through the psychological and emotional challenges they had as a woman versus actual gynecologic care?
Well, I couldn't put a percentage on it, but a lot of times they were commingled, especially during pregnancy and other times as well, during the transition of life, menopause.
I don't think people appreciate truly the challenges women face with their hormonal changes throughout life, right? That it's not just the medical side of things, but it really impacts their day-to-day life and their emotions and their relationships. Is that fair to say?
Very fair. It really, really does. And also a lot of physicians, especially non-gynecologists, don't give that enough attention. Mm-hmm. But the transition through menopause is a very significant aspect of their lives, physically and emotionally. Their body changes physically. As they lose their hormones, things change. Vaginal dryness sets in. And many women don't understand that that's part of it or what's in store or what's to come. The emotional aspects are equally important. A lot of women call it brain fog, and I think that's a fairly accurate term for a lot of times their emotions. But their emotions are more fragile. Their body's changing. They have the brain fog. And these are very real things. But they can be treated. And I spend a lot of time doing that as well.
You brought up just right now a lot of things I'd like to dive into. First comment is, I don't think in medical school we really learned to separate how to treat men versus women. And there is a difference, you know, biologically, hormonally, there is a difference. And I appreciate you bringing that up because we tend to just get this very skewed sort of white male medicine, for lack of a better way of putting it.
Oh, yes.
And it's very one-sided. You look at most of the studies that have been done that have been pivotal in general health, and it's very much skewed, but yet it is very different when you're talking about a woman. And then even in a woman's life, what she is going through in her 20s versus her 30s and 40s versus postmenopausal is very different.
It is. And of course, I trained some years ago, and at that time, as you say, it was geared towards white males. So was indeed the case. In fact, when I was training, premenstrual symptoms weren't even believed to be real.
That is
They
unbelievable.
thought they were psychological.
Ah,
And of course, there was the famous story about the physician in Britain, the lady who got her client acquitted because of PMS.
oh my goodness.
That was a big story at the time, acquitted for murder.
Wow.
And she became quite an international celebrity, came to the U.S. I even got to hear her talk one time. But anyway, she publicized the issue, and all of a sudden, people started realizing what it was. And now we even have treatments for that as well.
That'll certainly change the public discussion on something, right?
Yes.
I mean, correct me if I'm wrong, but I mean, hysteria, hysterectomy, removing of a uterus,
That's
I mean,
the origin
isn't the
of the
actual origin tied?
That's the origin of the term, yes.
Yeah. I mean, it's amazing to think what barbaric things we either did or thought of, quote, back in the day, but this back in the day was in your career.
And in my gynecological text that I still have today at the time, this has been some 50 years now probably, there was a situation called housewife syndrome.
Oh, please tell me more.
If you can believe that. Well, it had to do with a lot of the emotional things that you might expect, and probably sprang from the boredom, the limitation their lives were subject to at the time.
Mm-hmm. I mean, really, when your career started was almost part of the women's liberation. I mean, I can't imagine.
Very much so.
That probably you saw maybe in medical school and residency before, because you started practice in the early 70s, is that correct?
Mid-70s, yes.
So, you think about what the 1950s or 60s housewife, how she was supposed to act and what was allowable, and how much emotion must have just been pent up. And yet we know today with certainty there's medical, background to it that, women's hormones are evolving not only on a month-to-month basis, but also in different decades of life. And to think that women just had to have this very composed, sort of put together stoicism about them 24/7.
Well, as you know, men have emotional changes as well, but in a male-dominated society, they are suppressed.
Yes.
And we focus on the female side.
Mm-hmm.
But it's a two-way street.
Oh, definitely. I mean, it's okay for a man to, be angry. He's just being
Exactly.
assertive and,
Exactly.
an alpha. If a woman does it, she's labeled the B word, right?
That's correct.
Yeah. Let's go back. You talked a bit about menopause and some of the symptoms. For our listeners, can you just break down, what really happens during menopause, beyond the sort of the cliches? Help us better understand what actually menopause is, what's occurring. And, you mentioned, some of these symptoms, sex pain due to vaginal dryness, brain fog. This is not normal aging. This is fixable. Why do women suffer in silence? So, let's start with, what is menopause, dive into the symptoms a little bit more, and then, what can we actually do for it?
Well, menopause is actually the cessation of ovarian function. A woman is born with all the eggs in her ovaries that she'll ever have. And as she loses those over the years, the follicles that produce those eggs also produce the hormones to a great degree. And eventually she literally runs out of eggs. The ovaries stop producing hormones. And the classical initial symptom, of course, is the occasional hot flash or hot feeling or sweats, night sweats, those kinds of things. That's usually the tip-off that we're entering menopause. And there are blood tests to prove the point, although they're not one-to-one accurate. They give you an idea of, yes, this is probably what it is. But then other symptoms go along with that, the emotional symptoms, the physical symptoms, the vaginal dryness, which is a really big problem. And a lot of women don't know that it's so easily fixable.
Can you speak a little bit more to that? We've brought up on this show before, and other health experts have, the Women's Health Initiative, that landmark study, which I believe was 2002 in that time was released, which essentially, for lack of a better way of putting it, made it seem as if hormones are dangerous and evil. Now, you had years of practice before that study came out. In fact, first half of your career was before then. And then you practiced after that study. Walk us through kind of how you used to manage women, how that study impacted things, and what women really need to know about the results of that study. Because I know you and I have talked about this offline. It's been grossly misinterpreted.
The study was originally intended to show the hormonal benefits regarding cardiovascular disease. It had two wings that were not usually discussed. One side of the study examined hormone intake in women who had a uterus and those that did not. The significance of that is excessive estrogen by itself over time will overstimulate the lining of the uterus, the lining that grows and sheds as a period each month. And to the extent that even in some cases could result in cancer of the endometrium or uterine cancer. So to counter that, progesterone was added to balance off the estrogenic effects, to prevent the overgrowth and the complications that could ensue. So half the study included the women who took the progesterone. The other half of the study was women who'd had hysterectomy and therefore didn't need the progesterone. Mm-hmm. And as I said, the study originally was designed to look at the cardiovascular effects of hormones, hopefully from a positive standpoint. Early on in the studies, it became apparent that some women were having more issues than others. But what was not delineated was which side. There's a difference in hormones. There's a difference in women taking the synthetic progesterone or progestin versus those that took nothing. There aren't good studies on this, but I've always thought that the natural progesterone products were probably more beneficial and less problematic, but the studies really haven't been done in enough detail to demonstrate that. But for sure, we knew the synthetic hormones were making a difference because in that side of the group, the women that took the estrogen only had less breast cancer than the group that took both hormones.
That point on the breast cancer, if I remember, they reported a 25% increase in breast cancer risk, but when they looked at the absolute risk, meaning how many more women actually got diagnosed with breast cancer, it was 1 out of 1,000. It went from 4 out of 1,000 to 5 out of 1,000, but when you go to 4 to 5 and do some math, it's a, quote, 25% increase, right?
That's right. It sounds much higher than it actually turned out to be.
And it was non-lethal, is my understanding as well. There's never been any study showing that
the increased breast cancer was the hormonally sensitive kind, which is the least aggressive of the breast cancers. As far as the cardiovascular effects, those results were skewed by the age of the women in the studies.
They're much older. They smoked. They were already into menopause.
They were much, much, much older. Mm-hmm. And it became apparent later that the cardiovascular effects in these women, and these effects had to do with the coagulability of blood and therefore potential strokes, potential heart attacks, was due to the fact that these ladies already had been off their hormones, so to speak. They had been postmenopausal for probably 10 years or more.
Right.
And during that time, they would develop their plaque, their cardiovascular problems, and then to immediately put estrogen on top of that did seem to disrupt the plaque to some degree. Mm-hmm. So we tended not to start hormone therapy after someone had been 10 plus years postmenopausal. Starting it at the time of menopause actually did seem to help from a cardiovascular standpoint, and certainly from the other physical issues that we've mentioned. The physical issues like vaginal dryness is such an easy one to treat. It doesn't even require systemic hormones for those who still are afraid to take it. The topical version works just as well on that particular symptom. Mm-hmm. But nonetheless, hormones were hormones, and the whole lot were given a black name because of that 2002 study, which fortunately is fading into the background now.
Did you see later on in your career sort of a shifting back here where more women were coming in and having these informed discussions and more open to the idea of systemic hormones?
Absolutely, especially the ones that were most symptomatic.
Mm-hmm. Yeah, because they were miserable.
Exactly.
So if I heard you correctly, I think there's two things that women need to hear from this is that number one, timing matters, and that starting hormones early on are going to be safer and make a bigger difference. And that other risk factors have to come into place, that it's not a one size fits all. And it's possible, say, a woman with a very strong history of breast cancer in her family with, minimal menopausal symptoms, maybe she doesn't want to be put on hormones for those reasons. Whereas someone who's very symptomatic and is a lower risk for breast cancer, you might want to more strongly consider it. So it's very individualized.
Very, very much so. Absolutely.
Yeah. That's all fantastic. As a urologist, I also always go to, the bladder and how that's affected. And
hormones affect that as well.
Yeah, I mean, we know that overactive bladder symptoms are worsened by the postmenopausal or low estrogen state. And I know you've done your fair share of incontinence procedures, but talk just a moment into urinary incontinence and how that impacts women, what you saw in your career, and how not only hormones, but there's also minimally invasive options out there to help fix this bladder leakage. Because again, women tend to suffer in silence. Tell them why they should really address this.
Stress incontinence, the lack of the ability to control urine leakage, is both related to physical changes and hormonal changes. A lot of the physical changes are because of childbirth that has loosened some of the tissue, so to speak. Mm-hmm. But hormonal changes, the vaginal tissues and the perivaginal tissues as well, are very sensitive to hormones. And when they are withdrawn, they tend to atrophy, become drier, less pliant, less functional. And that's where the hormones come in. Of course, the anatomic aspects of it, we now have minimally invasive procedures to correct that by putting a small sling or a piece of synthetic tape under the urethra to support it during increased abdominal pressure, coughing, sneezing, etc. Mm-hmm. So yes, stress incontinence is something that many women have borne in silence, and sometimes not knowing the treatments that are out there.
Yeah, we've even started doing the Bulkamid procedure at our practice.
That's more of a urology procedure than a GYN, but yes, I'm aware of that. Yes.
Yeah, used to do, I think, a lot of the, coaptite, the collagen, and those things just didn't last, but we now have a bulking agent that can treat the stress incontinence. We can do this in our office, but point being, throughout your career, you saw women suffer in silence, thinking either, A, there's no good option out there, or
and the earlier operations weren't that great, to be honest with you. The so-called anterior repairs that we used to do in vaginal surgery to tighten the bladder neck from that standpoint were not as successful as these newer minimally invasive techniques have become.
And you also lived through, as did I actually, the sling controversy, where all of a sudden, if you use any mesh down there, it's, quote, bad and evil. And we've all seen the television commercials with the attorneys trying to chase ambulance and get women to sue doctors. But you've been putting in slings in women for decades, so have I. Speak just a moment to how did that all get thrown in as this myth that mesh is bad and how safe a midurethral sling is?
Well, going back to the original surgeries, the problem was using natural tissues in these weakened areas did not always last, even when the result was positive.
You're taking weak tissue and trying to reinforce it with weak tissue.
Correct.
Yeah.
Yeah. So the idea of using a mesh support system in that to increase its strength came about. It actually worked quite well as a supportive structure. The problem with mesh, or one of the big problems with mesh, was the technique required to get it placed at exactly the right strata of the tissue with the right tension. And to make sure that after they became menopausal, they continued to keep the tissues estrogenized. Otherwise, as they thinned and became atrophic, they could actually expose the mesh. So mesh fell out of favor because of those reasons, and a lot of people were putting it in that were not technically well trained to do that. Mm-hmm. The sling is a much smaller piece of mesh. It's like a small ribbon. And placed underneath the urethra where it is has led to very few problems from that standpoint. And of course, the other procedures like the bulking that you mentioned have been well tolerated as well.
Mm-hmm. So needless to say, you did this for just a little bit, and this idea that every woman came in with mesh complications is really blown out of proportion. But certainly you want to go to someone who's well-trained at doing these and uses the best products.
No question.
Yeah.
No question.
Well, Dent, just a couple more questions, if you don't mind. You've been very generous with your time. What's the most surprising thing you learned from your patients over the course of your career? I'm sure you've had just some amazing experiences and stories with your patients. You as a man have taken care of women for most of your professional life. What did they teach you? What did you learn from all these women you cared for?
I've always enjoyed the interaction with the patients themselves. That's been very rewarding. The long-term relationship that you develop in GYN practice is rewarding. I have 3 generations that I've delivered over the years.
Wow. So
the grandmother, the mother, and the child.
Unreal.
That was on one occasion. Over the time frame, the interesting things I've seen, number one, the greatest change was the introduction of ultrasound. When I trained in Emory in the early 70s, we didn't have ultrasound. So we didn't know if there might be a second baby in there.
Wow.
We might not be sure exactly what position it's in. And it was always interesting to say, oh, there might be a second baby here.
Almost like a secret Santa here, right? What am I going to unwrap and
Secret
find?
Santa indeed.
Right.
But I think women have taught me to listen, to pay attention. When I was in med school, there was a very famous internist who always said over and over again, listen to the patient long enough and they'll tell you what's wrong with them.
I love it. Such great advice in today's...
Great advice. I've never forgotten that over the years. Listen to the patient long enough, give them time, and they will tell you what's wrong with them.
Well, Dent, I think that speaks to why 3 generations of people wanted you to be their OBGYN, because you did listen. And one thing that struck me from the moment I met you is how beloved you are in your community and still are. And people come up to you, and you certainly have been an idol to me as to, one day when I grow up, I want to be Dent Williams because he's the definition of a true gentleman physician, a scientist.
You're way too kind. You're way too kind.
Well, I'm married to your daughter. She did slip me a little money to put that in there. But Dent, would you do it all again? We live in an age now where up to 40% of medical students right now have already decided they're not going to care for patients. Most of my colleagues are burnt out. I mean, you had a long, illustrious career. Would you do it again? And what advice would you give to today's physicians?
Well, going into medicine at the time I did, we expected to work hard. I mean, and maybe we didn't prize life balance quite enough. Sometimes I have some guilt over that. But overall, I'd do it again. I'd do it again in a heartbeat.
Love it. Love it. Well, Dent, why don't we finish with one last... If you could share one women's health message to your beautiful daughters and granddaughters and any other woman listening here, what's the one thing you wish women knew about their health or did? What's that one piece of advice we can leave them with?
Well, I guess the main thing is stay on top of their health. I mean, checkups do matter. Pap smears are still important. One of the biggest innovations has been the vaccine against the HPV virus that causes cervical cancer, but it's still important.
Breast cancer screening.
Breast cancer screening, absolutely.
Talking about your hormones. So really partnering with a women's health specialist to get checked out because you don't have to suffer in silence.
Indeed, that's right.
Well,
and don't be afraid to bring up sensitive issues to your gynecologist. He's heard it all before, or she has heard it all before. And don't be embarrassed. These are things that we deal with, and in most cases are fixable.
Yeah. Well, Dent, I mean, that's the only complaint I have about you. 40 years, and I've yet to get one real good story from you. You're too much of a gentleman. Ladies.
Well, I can tell you a lot of interesting patients I've had.
Ladies, he's like Fort Knox. He does not share anything about any of you. So trust me, your secrets have been safe here.
Gynecologists are the best secret keepers around.
I bet you've heard it all. I bet there's certain things. I bet there's certain things you've heard that it's probably good the husbands didn't hear.
That's right.
So we'll end on that.
Just the tip.
Dent, thank you so much for coming here today.
Well, thank you for having me. It was a real pleasure, Joe. Thank you.
That was awesome. So, Stream Team, we're just going to end it here just because I can't think of a more perfect way to end this episode. Such a wealth of knowledge here. And really the action item is please get checked out. Women, you take care of us, the children, your friends, everybody but yourself. But there are other wonderful physicians like Dr. Dent out there who can help you optimizing your performance in the bedroom, the bathroom, the boardroom, and I consider the home the most important boardroom that's out there. So with that, thank you so much for joining us today. Remember that we're all works in progress and that mistakes are opportunities to grow. Just show yourself a little bit more love and kindness. Have a beautiful day. Bye now.
Thank you for listening to this week's episode of Balls Deep. If you'd like to join our Stream team of listeners, please click the subscribe button on your favorite podcast platform. For more information about our practice, Pazona MD, please visit pazonamd.com. This podcast is for informational purposes only, and the content is not intended to be a substitute for professional medical advice. The show does not constitute the practice of medicine. No doctor-patient relationship is formed through this podcast or any of the social media channels related to this show. The use of this information is at the user's own risk. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions.